I'm Charles Shapiro, President of the World Affairs Council. I want to start by thanking our partners in this endeavor, that CARE USA, the Carter Center, and the Center for Strategic and International Studies. Michelle Nunn, Paige Alexander, and Steve Morrison helped us figure out how to shape the program and whom to invite. Our presenting sponsors are the UPS Foundation, Avanos, and John Snow Inc. Our supporting sponsors are Pain Care Labs, Dr. Amy Baxter, the Atlanta Global Studies Center, the Georgia State University School of Public Health, the GSU Center for Urban Language Teaching and Research, the Kennesaw State University Wellstar College of Health and Human Services, the Morehouse School of Medicine Office of Global Health Equity. We're going to start this afternoon by talking about India. Back in January, everybody in India was so confident that India somehow had reached herd immunity and that there was a special Indian case and they had done so well and had defeated COVID. And then the second wave hit in late March and April. We're going to start with a scene setter with Ramanan Laxminarayan, who is the director of the Center for Disease Dynamics, Economics, and Policy, which is based both in Washington and in New Delhi. And he's the founder of oxygenforindia.org. Mr. Laxminarayan is joining us from Princeton, New Jersey. Our moderator is Paige Alexander, who's the CEO of the Carter Center for almost exactly a year now, and a member of the World Affairs Council Board of Directors. Ms. Alexander is here in Atlanta, where I am. So I'm going to turn this over to you, Paige.
Great, thanks, Charles. Ramanan, it's nice to have you on. I think as we had talked about, a number of us don't fully understand the effect that COVID has had in India. It's been said that India could see 1 million COVID deaths by August due to, quote, a self-inflicted national catastrophe. So with New Delhi being roughly as dense as New York City, and many of us who are on this who experienced in New York City 30,000 residents per square mile. So we know what a ghost town New York looked like at the height of the pandemic. So can you tell us about what you saw in India and the switch that you personally made from COVID researcher to COVID relief?
Thanks, Paige. Thanks for having me, and to Charles as well. As you correctly said, Delhi is almost exactly the population density of New York. This is a strange coincidence. And I was in Delhi just 3 days ago when I flew to Princeton. And New Delhi is under a lockdown right now. It has been for the last 5 weeks. And the lockdown was initiated when cases started climbing to a point when all hospitals were completely overwhelmed. People were dying because of lack of medical oxygen, and there was simply no beds to be had. And it was utterly, it was a calamity. It was of a kind. It was a humanitarian crisis that I've never been witness to at that scale. It was like living in a war zone. You knew someone was dying every hour or two. Messages begging for oxygen or for a bed or indeed anything. And this is not, this is not just people who without means. These were people who, they were CEOs of companies. They occupied the highest positions of power in the Indian government, or they had. But it didn't matter. It didn't matter who you were. When it finally came down to it, there was no oxygen, no matter who you were. And it was a situation which India had avoided during the first wave, largely because of a very strict lockdown that was imposed when India had only a few hundred cases and 10 deaths. And that lockdown was prompted by epidemiological projections that we had made, which basically said, listen, this is going to be just as bad here as anywhere else, but because of the size of the country, it's going to be absolutely unmanageable. There is nothing unusual about Indians. The heat is not going to kill the virus. The BCG vaccination is not going to help. It's not going to be the hydrochloroquine. It's not going to be the exposure of Indians to other viruses or bacteria, which people thought would give Indians an exaggerated sense of immunity. This is a brand new virus, and every human being on the planet is exactly the same in the eyes of the virus. There's literally nothing that's different. And fortunately, that lockdown came into place. It was poorly planned, but at least it happened, because but for that lockdown, India would have faced the same kind of wall of cases that it witnessed this year. It would have seen that last year itself. And we did a large COVID epidemiology study that was published in Science last October or November. And this was based on 3 million contacts traced and in 2 states, Tamil Nadu and Andhra Pradesh. It was the largest COVID study to date published anywhere. And what that showed very clearly, amongst other things, was that lockdown managed to knock down the transmission of COVID significantly. A reproductive number of about 3 or 4 down to less than 1.2, which means that for every person infected, only another 1.2 people were infected. And that was not to be this year because there was the sense that although the lockdown had averted the worst of COVID, there was a sense that COVID itself was over, which was not true. And there was a return to normalcy. But beyond that, there was almost the sense of I would say hubris, right? Which is that India has done so much better. We can have the Kumbh Mela, this mass bathing event. You can have the election rallies, and none of it really matters. And the virus came back with a vengeance because effectively the country was chasing the virus rather than the other way around. So that's the context in which I had to switch from being a researcher, and I did this because a very close colleague of mine was in hospital. He had an ICU bed, which is rare for people at that time, but they kept shutting off the oxygen at night, every night. And his oxygen level would plummet to 65 and 70, and you're supposed to have at least 95. And when we looked for oxygen, there was none to be had. And so we started Oxygen for India in that context. I'll tell you more about it, but this is really what's happened in India over the last couple of months. It's been catastrophic to an extent that I can't really explain. I mean, the media coverage has been extensive, but it doesn't do justice to just how bad things really were.
Yeah, well, I think since February, I read that India's oxygen requirements have increased 15-fold. So it now needs nearly 3 times as much medical grade oxygen as it did during the height of the first wave. So can you explain a little bit more about what Oxygen for India actually does and how you coordinate with the government and with other donors?
India actually has a lot of oxygen because any steel plant, any sort of industrial facility does use oxygen. And at normal times, only about 15% of India's oxygen production is diverted to medical oxygen. The rest is actually industrial oxygen. But the demand for oxygen went up 10x in that period. And there simply was not enough oxygen to be had, even though all of the other uses were curtailed and all the oxygen was diverted to medical oxygen. That was one thing. The other part is that the parts of the country where oxygen is available and generated are very different from the places where it is needed. So the capacity to move oxygen from one place to another, even if it's just 100 miles, is just impossible. You can't move oxygen by air. It's not safe. An oxygen tanker typically can drive at about 30 miles an hour. You can't be speeding down the highway because it's dangerous to do that. So if you have oxygen which is just 600 miles down the road at an industrial facility, that's going to be a 20-hour ride to get one tanker over. And India just didn't have the number of tankers available either. That's one set of issues. The second is that even when that tanker comes into a city, it doesn't matter if that oxygen is just 100 yards away from you. If there is no pipe or if there is no cylinder to get it to you, then you're out of luck there as well. So Oxygen for India was really about solving this last mile connectivity, which is how do you get oxygen to people when they really need it? And second, the lack of oxygen was a reason why many people were not leaving their hospital beds, because even though they were better, they still needed supportive oxygen at home, which is not available. So we were holding up a lot of critical care beds because of this lack of oxygen at home. So Oxygen for India was really this idea that if you could get oxygen to people and send them home with supportive oxygen, you can open up critical care bed capacity, which is really the most limited sort of resource in that setting. And that's what we managed to do. Fortunately, COVID itself started coming down because of the lockdowns. And I don't think we're done with it yet, because until India is vaccinated to a significant extent, COVID will come back. But that's what Oxygen for India does. And today is only the 37th day of that entity being in existence. I mean, we raised a lot of money in just the first 2 weeks. We built a team of 150 people that are across 8 cities, and now we start with 8 cities. Now they're in 20 different locations. We send cylinders and concentrators into rural India. This is not stuff that I generally am equipped to do or do. Just happens to be that I just couldn't sit and watch this catastrophe continuing, and it really needed it just needed to be dealt with. So I have to tell you, the last couple of months have been extremely traumatic, but I think we're at least in a better position with respect to the caseload right now.
I mean, it's incredible that you got involved this way. I'm curious, have you found that the government has been responsive? I know those of us who work in international development, you're always trying to make sure you're not duplicating efforts. It sounds like you're really filling a void. Have you been able to work with corporations and with the government or foreign aid agencies?
So most of the money we raised happened to be in the US, because this is where I know people. And so a lot of big corporations stepped in, whether it was Logitech or Verizon Media or a bunch of venture capital firms, or United offered to just ship equipment from here to India for free. Flexport, which is a cargo handling agent, said they'd do stuff at pretty low cost. We had so many people step in to help and fill gaps really quickly. All this happened in the space of very short amount of time. The whole Perot organization of Ross Perot Jr., they stepped in to help. They offered to fly stuff on their personal aircraft across to India. But it's not just us. There's been other entities that we work alongside that many people have been very generous, particularly in the US, but also around the world, but particularly in the US, because there's a large diaspora and people who are connected to India. There's a company called UiPath. UiPath is a robotic process automation company. I'd never heard of them. They went public just last month they have a $26 billion valuation. And this was, I believe, one of their first CSR projects, their corporate social responsibility projects. They came through and they said, we'll give you $1 million to get this stuff done. So I have been truly humbled by how many people stepped in to help. And of course, on the other side, sadly, the government has been struggling, both at the state and the center levels. They have been far more in responsive mode rather than, really in terms of having prepared for any of this stuff in advance. But I think that in the spaces in which we were working, which is to get people oxygen at home, this is not a government plan or function at all. So I don't think we were duplicating anything that anyone else was even thinking of. But it was a very essential step because, again, as we've evolved, I think people now realize that lack of medical oxygen is an issue at all times. It's not just a COVID issue. It's an issue for children with pneumonia. It's an issue for expectant, mothers. It's an issue for people with cardiovascular disease. It's an issue for people with trauma and who've suffered blood loss. So you need oxygen all the time. And oxygen is something that we've known since the 1700s as something that's useful in medicine. And it's just unconscionable that we don't have medical oxygen available everywhere in the world, to satisfy everyone's needs. We do workarounds around it. And I think it's now time to use this COVID situation to now build an infrastructure, not just for India, but for Africa as well, so that we never have people die because of lack of medical oxygen. It's just not something that we should ever allow. It's such a cheap intervention, right? A tank of oxygen, it costs about 70 cents to fill up, 70 cents. You need about 10 tanks for someone who has COVID. You're talking about $7 of intervention to save someone's life. I think we should just do it.
Well, as you said, with all the challenges that we've had with COVID, there's also a lot of opportunities and recognition on things like this. And I know the Carter Center is looking at mental health programs because what COVID has caused people to do. I mean, in India, a lot of us have seen the pictures of people standing in line with oxygen tanks, waiting to have them refilled so they could bring them back home. So the fact you fit this niche and in 37 days have managed to address it is really quite remarkable. I think one of the comments you made, you said people had not realized, and it's not just about the oxygen or lack thereof, but people had not realized about the disease and how difficult it was going to be in the second wave. You know, you've said before, it's not urban, it's not rural, it's not north or south, it's everywhere. You know, can you give a better sense of how the spread happened? You had mentioned the political rallies and the celebrations, but is that really the crux of how it ended up countrywide in a much more rapid way than we had expected before?
Right. So the political rallies and the religious gatherings, it was not so much that they were necessarily the biggest spreader events, although they possibly did, but it was much more the signaling when the government says it's okay to have these rallies and participates in these rallies, and the political leadership is encouraging people to be there without masks. That's a very there's dissonance, right? When on the one hand you're saying COVID is important and you should wear masks, but at the same time you have rallies where no one is wearing a mask, then people pick up on that dissonance and say, well, wait a minute, maybe it's not that important anymore. So it is a signaling that happens when there's not a clarity. And I think we've seen that in this country as well. When there's, when the president wears a mask, it sends a signal to everyone else that they should wear a mask. And I think that's very, very important. And the lack of that uniformity of action and what you say and what you do, if those don't align, then then a lot of people just don't follow along. And I think that's really where the damage was. And COVID was much more visible in urban areas because that's where the hospitals are. And, truth be told, that's really where you see the worst of COVID, right? When you have hospitals. There are many parts of the world which don't have hospitals, and you don't see that same body count just because people with COVID are dying at home. And they don't come to a place and then you have these large numbers of deaths. And therefore, you get the sense that things are better, but things are not better. They just happen to be dying at home without any medical care, and that's pretty much it. And that's what's happening in rural India even today. You've heard about the bodies floating in the Ganges. That's really people who've died at home, and there was no place to really cremate them. And this is true in many other countries in South Asia as well. When their hospital infrastructure is not strong, then these are invisible COVID deaths. Which is what you continue to see across rural India. But the behavioral response also kicks in, which is that when people see the mortality count, that induces them to wear masks or to be careful in ways that 1,000 public service messages could not really have that same impact. And that's why that visibility of COVID serves a useful purpose, as we've seen with HIV. When HIV was kept hidden, people really didn't respond. But when it was made public and you were told, listen, this is how it transmits, this is why people are dying, then we saw this in Uganda first, in Thailand, even in India, that people started responding because at the end of the day, that behavioral response is really the strongest force that shapes an epidemic.
Yeah, well, it's interesting you mentioned HIV/AIDS because you've seen Dr. Fauci and Dr. Rochelle Walensky, and these are conversations that will happen later in the World Affairs Council's panel discussions, but on information and disinformation. And I think that we question on India, was it complacency? Was it, the lack of leadership? What actually led to this? But you've laid it out nicely. So one of my questions is, it peaked in India, but not in Nepal or Pakistan and Bangladesh. So why do you see a difference in the region? Was it leadership? Was it people wearing masks? Was it better information?
Actually, things have been bad in Nepal as well, to be honest. So Nepal has had a trajectory which follows India quite closely. I think wherever testing has been adequate, you're seeing the cases and the deaths. And where testing is not adequate, then you don't see it. This is true for rural versus urban India. It's true within India itself. The southern states, whether it's Maharashtra or Tamil Nadu or Kerala, appear to have a worse situation with COVID compared to Uttar Pradesh or Bihar. But that's only because these states test more. So the same comparison that you'll see within India is also the difference between India and Pakistan. India is testing rates per capita are far greater than that of Pakistan or of Bangladesh, as a matter of fact. And hospital infrastructure is also quite different in these countries. So I think when you have lower testing and lower hospital bed capacity, per thousand population, COVID is not going to be as visible. Doesn't mean that it's not out there doing damage. It just is not. It's just not visible. And in some instances, it's because testing is not available, and that's one way to do it, or that's one reason why this happens. But the other reason is, in some cases, testing is actually suppressed. Governments don't want to know. They actually discourage testing. That has happened within India as well. And in those situations, you're basically taking away the ability of your population to self-protect, because who cares about what the aggregate number is? That's interesting to epidemiologists. I mean, at a human personal level, why should more people die just because of governments wanting to project an image of COVID control that is quite different from what the reality is?
True. Well, so, and what are the implications, do you think, on the Indian example for other densely populated countries like Nigeria or the Philippines or Indonesia? I look at the comparison of New York City and New Delhi, and I recognize, as I said, what a ghost town New York City was. And I'm sure you walking around New Delhi now is quite different than your experiences before. So what are the lessons learned? What's the takeaway on this?
I would say there are three takeaways. There's probably far more, but the three takeaways are: number one, there is no exceptionalism. Nobody is outside of the target range of this virus. Doesn't matter if you're African or Asian or Filipino or Japanese, whatever. Everyone is at risk, and I think that people have the sense that it's happening there, it's not happening here, and therefore we're special. If there's anything which has been common to the world, it's that every country has felt that sense of exceptionalism and has been proved wrong. So that's the first thing. The second is the time to prepare is not during the crisis, but before. Medical oxygen is something which has been an issue in Iran, issue in Italy. It was an issue even in New York. So why would someone not prepare for medical oxygen today in Nigeria? There should be an oxygen for Nigeria right now, and do it before there's a massive number of cases that overwhelm the system. That's number two. I think the third thing is really around a piece which India didn't do so well on, which is really on medical care itself. Now, India does have very good medical institutions, but the vast majority are not those. There's been a lot of irrational, unscientific use of drugs, ivermectin, plasma therapy, hydrochloroquine, using Fabiflu, using steroids very early on, using remdesivir at widespread way rather than very specifically at periods where they're indicated. I think these mistakes have been made because the response was not led by science. It was led by perception. It was led by politics. It was led by, I don't even know. I mean, I can't even explain why some of these are still in the clinical guidelines. So I would say that for other countries, get those pieces in place, which is get your treatment guidelines very much in place and realize that COVID is not a disease that gives you a lot of time to get things wrong. You have to get it right from the beginning, and you have to, the window of opportunity is really, really small to get those things right. So those are three. The last thing is, of course, vaccination, which is, I think, the only exit for all of us. And I think there's been huge inequity, both within countries and across countries. And I hope this is a place where the US can step up and say, just like the US played a big role in the smallpox program globally, or played a big role in the stuff that the Carter Center is involved in river blindness, for instance. I think those are areas for US leadership, and to just say, listen, this is just, if it wouldn't be the US, who else would do it? And the answer is nobody else would. So I think it's up to the US to do this.
Great. Ramanan, that's a perfect way to end. I mean, the three biggest takeaways being no exceptionalism, time to prepare before, and listen to the science. I think the US, I hope, we are not as myopic as we might seem at the moment. As Charles and I were talking about, you can go to your local grocery store and there's signs out saying, please get vaccinated, it's here. Whereas a month ago, people were trying to call to get their parents in to get vaccinated. The whole world needs to be in that situation. And so I do hope the US stands up and new leadership helps. That will be a conversation for future panels that we're going to have during the World Affairs Council meeting. So thank you very much for your time, and thank you for all you're doing in the 37 days. What you've been able to accomplish on the Oxygen for India front is really amazing and impressive. And so it's been a joy to talk to you.
I want to thank you. This has been great. I really like your emphasis, Ramanan, on no exceptionalism, that every country has thought that it was special and every country's turned out not to be special. That's something for us all to remember, and that we need to get it right before the crisis starts. Thank you, Paige Alexander, the CEO of the Carter Center, and Ramanan Laxminarayan, the founder of Oxygen for India. We're going to take a very short break here while we get the next panel set up. So everybody, take 2 minutes. And we will be back at exactly 12:30 p.m. Eastern time. Thank you very much.